Good morning. Good morning, everyone. I want to, it's my pleasure to make this introduction. This is Dr. DKurtycz. He's a friend and mentor of mine from the University of Wisconsin. Dr. Kurtycz is a graduate of the University of Michigan Medical School. He did an internship in pathology immediately after medical school at UW, but then he went to Kansas for 2 years of general surgery. He then saw the light and returned to UW.
I'll explain that.
Returned to UW for his pathology residency. Of interest, he also completed a fellowship in clinical chemistry in the early 80s. Dr. Kurtycz has been at the Wisconsin State Lab of Hygiene for the majority of his career. He's been medical director and director of its cytotechnology school since 1998. He has been chief of the cytology section there since 1985. Of note, back in 2000, he took in a wayward resident from the University of Kentucky as his fellow. So I have a very close relationship. But that would be me, moi. Dr. Kurtycz has been a leader in cytopathology for many years. He is section editor of the Diagnostic Cytopathology Continuing Medical Education section. He is on the editorial board of the Journal of American Society of Cytopathology. He has served on the ABP, the American Board of Pathology, for the Cytopathology Test Development and Advisory Committee, and has served in various capacities for the American Society of Cytopathology. He has been on its executive board, has been the secretary-treasurer, vice president, and is the current president-elect for the 2019 to 2020 year. As a leader in cytopathology, he's played an instrumental part in various committees for trying to standardize cytopathology reporting across the country and across the world. He's been on the Bethesda committee for reporting cervical cytopathology, the Paris committee for reporting urinary cytopathology, and now the Milan committee for salivary gland cytopathology, which he will speak to us about today. So please have a warm welcome for Dr. DKurtycz.
Thank you very much. Now to explain the surgery. At that time, after my internship in Path, which I'd always intended to go into, we used to have a Professor Jerry Abrams at University of Michigan. Jerry Abrams would stand up there, and the air would waft through his curly locks, even though there was no breeze, because he was just masterful, and he inspired a lot of us to go into Path. Anyway, I did my first year of Path at Wisconsin. Then my wife-to-be matched at Kansas, and their program had just been devastated by Scarpelli, who took everyone to Northwestern, and so it wasn't a place to do Path. So I went in for giggles to see what clinical life was like, and I did 2 years of general surgery, which I think made me into a better pathologist, and at least a tougher one. Anyway, today we'll talk about Milan in the context of the general development of standardized terminology. The obligatory picture of our medical center. This is a artist drawing, because this building doesn't exist yet, but everything else is here. And pathology is in this wedge. We are kept distinct from the rest of the hospital, and they tube all the frozens over to us. It's actually a nice environment. We have windows and an excellent group of young folks. And so to all of you, Bucky Says Hi. This is my wife, Tina, the one I went to Kansas for. Always, we just did our 40th, so. I do have a disclosure. I am a co-editor of the Milan Atlas, but all the proceeds from that publication go to the American Society of Cytopathology Foundation, which hopefully will continue its charitable works into the far future. Objectives for today, and if you have any questions, since we have a nice little group, please accept them at any time, but especially at the end. We want to discuss the reasons behind the development of standardized terminology systems. I want to describe the evolution of such systems and to highlight Milan. All of this, though, really had its beginnings back in crisis. That in 1987, there was an article in the Wall Street Journal written by Walt Bogdanich called Lax Laboratories. The Pap test misses much cervical cancer through lab errors. There were certain private laboratories, especially in Texas and California, who were cutting corners, either because of a dire financial need, that is, they were struggling, or because of a profit motive. They would do things which were not considered best practice. They would send slides home with the cytotext that you could imagine having a baby on one knee and a microscope on the other. They would come have cytotext in the morning be greeted by 200 slides on their desk. They would pay piecemeal, pay per slide. This all encouraged fraud. This encouraged errors. And it ended up with some women dying because things were missed. Organized pathology, organized medicine hadn't taken care of this, so Congress was going to. And that largely because of these problems with cytology, we got the CLIA 88, the Clinical Laboratory Improvement Amendments of 1988, which put constraints on the directors of the laboratories that who could be technical director, put constraints on personnel that what kind of certifications they had to have. And actually we had a national testing for cytopathology. Every practitioner has to take an annual test in order to keep practicing. It took a while for that to evolve, but it did. Well, Bogdanich got the Pulitzer Prize for this, and in many ways he did improve our practice. A lot of people were very unhappy about this, but we could not control ourselves. Because you had individual owners of laboratories saying, caveat emptor, it's my laboratory, I'll do what I want, and Congress says no. So the Bethesda system for reporting cervical cytology was a response to CLIA 88, and in fact, it was established a national standard. It became embedded in CLIA 88. It decreased the number of diagnostic tiers from previous systems in order to make it simpler. Not only board-certified cytopathologists practice cytopathology, but a lot of people in surgical pathology, a lot of people in general practice cytology because there just weren't enough of us to cover everything. And so not being specialists, they needed a simpler system. And Bethesda is this, but Bethesda also was pushed everywhere across the planet and in reimbursement schemes also, so people paid attention. There were new iterations to Bethesda cervical cytology in 2004 and 2015 with new information about HPV, natural history of the disease, improved diagnostic explanations, improved images were all added to a larger book. And so that exists. Next, Bethesda Thyroid followed. Like Bethesda GYN, it began at the NIH by Dr. Andrea Abadi, and it attempted to regularize thyroid fine needle aspiration. A lot of people were practicing it differently in different places, and a major contribution was to attempt to provide a literature-based risk of malignancy for all the different diagnostic tiers that they had, and to develop an international orthodoxy in the way you call thyroid fine needle aspiration. It's in its second iteration, and it is a worldwide standard. The Paris system was the third, and it was created to answer certain problems in GU cytology. Genital urinary cytology, we do very, very well at finding the high-grade lesions. They're flat lesions on cystoscopy that the urologist can't see, but we see them really well because they're huge, ugly cells. On the other hand, the papillary lesions that the urologist sees quite well on cystoscopy, we have a problem with. That the cells are typically bland and They have small nuclei. It's hard to tell them from normal cells, especially in instrumented bladders. And so there was always this frustration with trying to make these calls. Paris tried to fix that and attempts to standardize the terminology and focus on what cytology does best, which is find the high-grade lesions. There are some problems also with GU histopathology in that some of the lesions in the WHO and the ISIP publications call things carcinoma which don't invade and don't metastasize. This leads to scaring a lot of patients, confusing surgeons, and certainly was kind of a bane for cytology. So what Paris does, it says all those things that aren't invasive, that have no chance of being metastatic, we will put into the negative for high-grade carcinoma category. And people tend to like this. It's working out very well. Also, one of the novelties of the Paris system that it introduced placing questions in the last chapter for future research, so that every assumption that Paris makes, including criteria for morphology, can be challenged and verified, and gives a whole host of possibilities for new publications, which will keep the next generation of cytopathology in academia. There have been some efforts that have been in other societies, like the Pap Society Pancreas. The Pap Society developed this one on its own. There were some notable authors in there, Martha Pittman from Harvard and Lester Layfield from Missouri, who was at the Utah when he did this, but it attempts to standardize diagnostic terminology and generate a taxonomy for cytology, a little bit different than histology, especially for the set of lesions that are of a certain malignant potential, like PANNETs, IPMNs, and whatnot, those that you don't know if they're going to go bad or not, that might remain localized or not. Dr. Pittman came up with a term neoplastic other, which has its own risk of malignancy and some risk. And it's been somewhat controversial, but I think very, very worthwhile. And given that it was done by a society, it doesn't have quite the worldwide push that the other ones did, but it may be coming because Martha doesn't stay still at all. So now to Milan. So it is the most recent example of the published systems. And it follows the same sort of sequence, and that's what I'm going to try to describe, how we got there, how all of these systems evolved. We've developed a plan to get these things into publication, and it's essentially to improve cytology, improve communication such that FNA especially is going to be used in the future. Salivary gland cytopathology is useful but somewhat difficult, depending upon, again, the frequency of your exposure and your familiarity with the patterns involved. It has difficulties. You've got to have enough specimen material to make that library of patterns in your head such that you can do the interpretation. And you've got to be at a place where salivary gland FNA is accepted and used. The spectrum of tumors is somewhat heterogeneous, and some subsets have some morphologic overlap. Dr. Diana Rossi and William Faquin. Dr. Rossi is a professor of pathology and cytology at Universitario Gamaliel Rome, from Rome, Italy. And Dr. Faquin, who's a professor of path at Harvard and director of head and neck pathology at Harvard at Mass General, started off this effort in Milan. I'll explain the cities in a second. They were noting things in the literature that morphologic interpretation was variable. Different studies showed different sensitivities, different specificities, and the specificity of 48% is awful. Diagnostic accuracy of FNA for benign neoplasms is about 90%, malignant about 75%. But accuracy of tumor typing was not as great in the literature, and they know it could be improved. They took a look at things like Lavosi's effort, or I give her credit because she's a driving force for everything. Someone knows her, right? Virginia Volsi and her juniors, Sapella and Baloche, looked at a bunch of cases, FNA, and also correlating frozen sections to it. 220 cases, sensitivity 86, specificity 92, overall accuracy 90. 57 had frozen section associated with it, and some false negatives with frozen section, no false positive. But they looked at the overall sensitivity comparatively and found that actually frozen section was a little bit less than FNA in terms of sensitivity, same specificity, accuracy, a little less. However, when they combined the two, of course, it was a better result. You can describe an entity by any number of features, and the more descriptions you give it, the closer you approach to truth, right? The bigger the sample you have, the better the diagnosis. So given things like this, people began to talk. Success in salivary gland needle aspiration seemed to be quite variable, and it was dependent upon the case volume of an institution, the experience of the operator who obtains the sample, the experience of the team that interprets the sample, and a lot of diagnostic variation depending on where somebody was trained. But this is kind of obvious. And Faquin, in one of the early meetings, brought forth from different institutions reports on basaloid neoplasms with scant matrix. The first one was low-grade matrix producing neoplasm with basaloid features. The differential diagnosis includes basal cell adenoma, basal cell carcinoma, pleomorphic adenoma, adenoid cystic carcinoma. Recommend resection for diagnosis. So that was the first one. Same material, another place. Basaloid neoplasm with matrix success, basal cell adenoma. Same sample, next place. Atypical basaloid cells with mild atypia, C note, long note. And then negative for malignancy consistent with basal cell adenoma. This problematic, we needed to do something better. So the Milan team got together. That we had, I think this was the second meeting. I don't know if we were in Milan at this time. But there was sponsorship by the International Academy of Cytology. It can't be just an American affair. The American Society of Cytopathology and some other societies, Japanese societies, Chinese societies, Korean societies, all got in. 40 participants from 15 countries. Cytopathologists took the lead, but there were also head and neck surgical pathologists like Bill and head and neck surgeons. The goal was to generate evidence-based classification system that was user-friendly and internationally accepted. And we knew it's a long-term effort and correlated with a management algorithm that the surgeons obviously were interested in. The print atlas is published, and the web atlas will be out later this year. So how we did these things. In the early times, before times long ago, before Herbert Walker Bush, there was money at the NIH to do these things. Bethesda GYN, Bethesda Thyroid, all started off at the Natcher Auditorium, where they brought us all in and we could debate in a government facility, and it had a lot of cachet. But after President Bush had funds restrictions, we lost the Armed Forces Institute of Pathology, a lot of bases were closed, and there was no more money to do this type of activity at the NIH. So the societies said it was necessary, it was valuable in the first two episodes, and we have to do it on ourselves, by ourselves. Professional societies and individuals at academic institutions bore the cost of developing the next system. So Pancreas, Paris, and Milan were all done through the societies. And we had a pattern. We got a group together, posed the questions, and then started surveys. We use Qualifications survey, which is available at most institutions. It's just a simple survey software. It's a little bit more involved than, say, SurveyMonkey, but most of your universities have ready access to this. And we ran the first survey out from UW-Madison. We advertised it from websites of the professional societies, from their listservs, and social media sites, any way we could get the information out there. And we ended up reporting on this in Cancer Cytopathology. There were 49 questions related to taxonomies, practices, and diagnostic entities of salivary cytology. We got about 515 people, and it was good enough for a paper. And responses showed a lot of variation in diagnostic practice and subsequent management. Some things that were pretty clear, that participants believed that non-diagnostic rate should only be about 10% for FNA of the salivary gland. But really, there were a lot of varied opinions secondary to approaches for certain malignant or from lesions of uncertain malignant potential, sort of those intermediate lesions that are somewhat similar to what I mentioned for the pancreas. That is, you can get close to a diagnosis, but you're not sure if they're going to locally invade or possibly metastasize. So there was strong support for the development of a unified system for reporting. It did demonstrate confusion and diversity of diagnostic categories for descriptive reports, having no categories versus surgical pathology terminology. People were using all sorts of different things to try to get the information across. And there was no correlation with risk of malignancy. In general, very little correlation in our survey for clinical management. And limited use of genetic or immunologic studies in interpretation, at least among our participants.
Were those, the reporting people, were they cytopathologists, were they specialty, subspecialty?
Mostly they were academic cytopathologists.
Got it.
And I don't know if I have a slide on that, but mostly academic cytopathologists. So they 70% agreed on the need for a tiered set of categories. We break it down extensively in the paper, who did what. Yeah, they were mostly academic cytos and then some AP. Agreement on the need for clarity of communication, consistently terminology and risk of malignancy, and better exchange of data across institutions and to clinicians. And the really need for quality control in our systems is that somehow we have to check back with the clinicians. Are they getting the message? A lot of clinicians complain that they don't understand our reports. We have to do better. And trying to build that into the system. So, after the survey, we came up with 7 diagnostic tiers. We didn't want to make them too complex. They had to be understandable. And so we had non-diagnostic, non-neoplastic, and a typical category, AUS, but we want to keep that restricted as much as possible. Neoplasm's benign, and then neoplasm SUMP, or salivary gland lesions of uncertain malignant potential. For those that we're not sure about their behavior. Neoplasm suspicious, neoplasm malignant. And I'll explain these in a minute or two. From the literature, I tried to put as much as possible evidence-based risks of malignancy for a given diagnosis. Now, you needle a salivary gland because usually there's a mass there. It's not just you needle it because the gland is there. And so there's either a radiologic or a clinical reason. And so even in a non-diagnostic sample or even a non-neoplastic sample, there's still going to be some risk that you may have missed something. So from the literature, this is what we obtained, and these are the management recommendations, is that for non-diagnostic and non-neoplastic, you need to conference, and you may have to repeat FNA if it doesn't make sense. For atypicals, repeat FNA or surgery, again, after conference, that you really need to talk with the clinicians and radiologists to make sure that you're doing the right thing. And with the other ones, usually surgical follow-up is what goes on. And the proportion of cases, the largest numbers being at the bottom of the pyramid, you usually find more benign neoplasms, especially like pleomorphic adenoma or non-neoplastic. SUMP is down here. You get a crossover between most common and least common in the malignant entities, and we should have non-diagnostic, suspicious, and AUS being the smallest portions of this graphic and the smallest in numbers. Our surgeons had a lot of input, and they wanted us to consider questions. What goes through their minds when they have a report back from us and they have the clinical picture in front of them? Is an operation necessary? And if a resection is called for, what kind of a resection is needed? Extracapsular resection, superficial, subtotal, total resection. You're going to have to do a neck dissection where you have to sacrifice the facial nerve. They told us that being as specific as possible with the FNA interpretation provides the most help, which seems like a duh, but they stated it boldly. In the opinion of the Milan surgical pathology, FNA is more than a screening test, and given modern technology, we can do better than just the straight morphology. If a specific diagnosis can't be rendered, great help is given by differentiating the lesion into benign, malignant, and low grade versus high grade at minimum. And for non-trivial cases, preoperative planning is progressively done in multidisciplinary tumor cases. And input from the cytology pathology group is essential. So, role for FNA. The surgeon wants guidance and wants to do management with a strategic plan. Non-neoplastic, clinical management. Benign tumor, low-grade carcinoma, limited resection. Metastasis to parotid nodes, lymph node resection. Lymphoma, turf it to heme. High-grade primary carcinoma, resection, radical resection, and nerve sacrifice, node dissection. So, the classes. Our first is non-diagnostic, and you have a sample that's insufficient by amount or quality. Here we have a non-mucinous cyst, and you have a bunch of histiocytes in a particulate background, and this is not good enough. If it doesn't reflect the radiology and whatnot, we're going to have to go back. 10% non-diagnostic rate is the target. We don't want to see more than that. And we established a baseline of 60 lesional cells, much similar to thyroid fine needle aspiration. Got to see 60 lesional cells in order to be adequate. Something that actually surprised me, and I did grow to understand it, is that if you find just benign salivary gland, you just can't read it out as benign, especially in the face of radiological clinical evidence of a mass. That this was, most of the respondents to the initial survey said, no, if you just have benign, that's not diagnostic, and you should repeat it or find something else to do, or maybe have to go on the biopsy. So, acellular mucin or acellular matrix material does not fit into this criteria. Because if you have mucin, then you have to worry about a low-grade MEC, mucoepidermoid carcinoma, or if you have matrix material, it indicates that there's some sort of tumor there. And so it doesn't fit in non-diagnostic. Let's see if I explain these. Yes. And so this is like acellular matrix. So this would be classed out of non-diagnostic. Non-neoplastic. Absolutely no evidence of a neoplasm. Radiology is explained, and clinical findings are explained by what you find on FNA. Here, the top one is a chronic alanitis, and so inflammatory cells and reactive epithelium. That's fine. The bottom is a granuloma, which would be a chronic sialadenitis, and this is a loose granuloma with epithelioid and carrot-shaped histiocytes, which are typical of a granuloma. So all inflammatory, reactive, metaplastic entities fit in here. Acute and chronic inflammations, reactive nodes. But if you have tingible body macrophages in a polymorphous population of lymphocytes, then probably doesn't need flow. It will just be a benign lymph node. But if you see any monomorphism, or if you have any worry, then you need flow. And everything has to be always correlated with the clinical findings. So this is a tingible body macrophage with a bunch of lymphocytes that is derived from a salivary gland FNA, and then here's a allolithiasis, amylase crystals nicely displayed. Atypia of uncertain significance, ONS. So here's something from a mucinous cyst. Using a Diff-Quick or Romanowski type stain, you get that magenta color, which is a poor man's mucin stain or a poor person's mucin stain in the current age. And that is atypical. You got to find out the cell type that thing came from, which may well be an MEC. And unexplained cells, weird, strange, usually low number of cells here and there. This should be rarely used, and all the atypical categories should be rarely used, but there's always going to be some morphologic overlap between a non-disease state and a disease state, and morphology is never good enough to have pure isolation, and so always a case will cross in the middle. But often degenerate, atypical, or degenerate compromised material will be the most likely source of AUSs. It's a heterogeneous category, and many cases may require biopsy or resection after the correlation conferences. Neoplasm benign. Here are the classic lesions. Warthin's tumors, pleomorphic adenoma. Risk of malignancy is very, very low. Warthin tumor with oncocytic cells, the debris in the background, and lymphocytes, various chronic inflammatory cells. Pleomorphic adenoma with the matrix and epithelial cells. So schwannomas, other common tumors. SUMP, uncertain salivary gland lesion, or salivary gland lesion of uncertain malignant potential. And so you have some basaloid cells with some irregular matrix. Could be adenoid cystic, could be a strange pleomorphic adenoma, you're not quite sure. So it needs to come out and for a definitive diagnosis, but at least you can have the surgeon plan. You give them the information up front so they have a clue what's going on, and they like that. They don't like to come get things out of the blue. And then there's the pure basaloid neoplasm, which can at least will require a histologic evaluation to define it, and the lesion may be very heterogeneous in the patient, and so you don't know how well you've sampled. There's a lot of morphologic overlap, and again, may not show the tendency toward local invasion of distant spread. Risk of malignancy is about 35% by estimate, and you have there may be in this group benign neoplasms with worrisome features or low-grade carcinomas. We're hoping that as the genetic markers and immunologic markers continue to develop, you can class these things progressively out and decrease these sort of intermediate categories. Oncocytic neoplasms, clear cell neoplasms can fit in here. Suspicious. Usually it's lesions that are suggestive of malignancy but lack proof, and it's usually limited by quality or quantity. You have a scary cell or two, something like this cell, which looks like mucin vacuoles, and enlarged nucleus with a prominent nucleolus, and it makes you very worried, but you've got one or two of them on the slide. And so it needs to be elucidated. You've got to find out what's going on. Malignant, usually easy. Diagnostic, classic features, adenoid cystic carcinoma, acellular hyaline ball surrounded by basaloid cells, or you have a squamoid set of cells with occasional mucinous vacuoles, low-grade MEC. And it also includes other malignancies, metastatic malignancies, lymphomas, sarcomas, etc. But most of the category is fairly easy, such as this high-grade MEC with some mucin vacuoles and cells that are astonishingly evil. So ancillary testing is essential for fine needle aspiration's utility. we can tell so much from the morphology, but the immunos and the genetics will help us be more definitive and cause less trauma to the patient. Maximize what a needle rinse or a cell block can do, and can resolve basaloid, oncocytic, clear cell categories. What we can do with a fine needle aspiration is well known. We just usually always do direct smears with wet fixed and air dried, but the cell block is becoming progressively important in all sorts of systems where paraffin sections with immunostain, genetic probes, fish used to do a lot of electron microscopy back in the old days when I was growing up, but not so much anymore. And needle rinses, you can make cell blocks and cytologic preparations out of those. Genetic markers are in all the books and related to different entities. And so we're using. So before we publish the book in each one of these systems, we do an inter-observer study to make a baseline. That we have a system, we have all the materials ready, we're about to go to publication, and then we use the images from the planned publication to do a relatively easy test. In this one, something called Milan Inter-Observer Reproducibility Study, the MIRST, by the way, how am I doing for time? I'm good. We took 75 images from the few hundred or 300 that we had for the book and put them out there for people to look at and interpret in accord with the diagnostic tiers. Now, no one knew the system before. We just put the diagnostic tiers out there and see how people could fit the images in. We had done this for Paris, and we did this for Bethesda. In fact, for Bethesda GYN, we had done it twice. We done it once before the initial Bethesda was published, and we did it just before the last Bethesda book, GYN, was published. And we saw a remarkable improvement because of people's familiarity with the Bethesda system and acceptance of the diagnostic tiers. We did this one as the baseline. So 75 unpublished images were selected from the atlas. And we looked at all the diagnostic categories and degrees of perceived difficulty. We asked some demographic questions regarding certification and practice and volumes. And again, Qualifications software was used. We got some local biostatistical help and graphics from our cytogenetics department, which was marvelous. So we got about 647 people attempted to access the study. And we put in 2 qualifying questions. One was, who is Dr. Pap Nicolau? Put a picture up there. If they didn't know who Dr. Pap was, they were out. The second one was, what is a coilocyte? Okay, or a picture of a coilocyte, and they couldn't interpret that, they were out. We wanted to get rid of trolls and whatever. And neuropathologists, yes. So the participant certification included about 70% ASCP certified cytotechs, ASCP specialist cytotechs, IAC certified individuals, 13.7% AP certified pathologists, and cytopathology subspecialists in 38.1. Fellows and some residents. Okay. Time in practice, 0 to 54 years with a mean of 15.5. And most of the people belong to academic institutions, 17.6% from private hospitals and some from commercial private laboratories. And we got people from across the planet, mostly from the US, but from Asia and Europe and Central South America, and even some from Australia. Participant case volume was, for salivary gland, was between 0 and 500 cases a year. That must be a heck of a practice, with a mean of 91.9 cases, but a wide standard deviation. So some people are only doing a couple and some are doing a fair amount. Everyone uses direct smears, but there are a lot of other preparations too. Thin prep, probably for needle rinses, sure path, cytospin, and some people do cell blocks as a matter of course. Some people employ cell blocks as their main method, although that's a small number of looking at these things. And we were disappointed in that only about a little over 16% said that they regularly use any kind of genetic testing on salivary gland samples to try to help define things. We generated a heat map, which I want to show you. The technique is interesting for looking at, by inspection, a bunch of responses. And board-certified cytopathologists had the most consistent agreement with the expert group who diagnosed these pictures originally. Pathology residents did the worst. That'll show you that. Considering the whole study, about 42% respondents agreed with the reference interpretation as per general categories. And academic centers had better correlation than non-academic. So we made some pretty graphics, which again, just out of the software, Qualifications software is easy enough to do. And I won't belabor this, but by inspection, those folks are from the US and Europe, South America, other North America, etc. And this makes generating your posters really easy. You just have these pie charts and whatnot shown right up. And let's see, AP and cytopathology certified, and this is AP pathologist, so that's over half. So the heat map is interesting. This was a technique shown to me by Deb Schutt at the Cleveland Clinic, and it was a revelation when she taught me how to do this. For a study like this, you take all the categories that you used in your assay, in your survey, and then you break them down. You put all the non-neoplastics together, non-diagnostics, neoplastic benign, suspicious malignant, and then you substratify them by percentages, putting the highest percentage of agreement on top and the lowest percentage of agreement on the bottom within the category. Then Excel, the spreadsheet, lets you put a color on that. For the highest number, you can put a green, and then make a gradient down to the lowest number. So by inspection, I can see that for all comers, these had the best agreement, and this had the worst for the non-diagnostic category. The biggest one, the malignant, there was general agreement, and this is all comers with this category, and the worst agreement with that question. Now, you can substratify this and break this out for different categories. This is all comers. This is ASCP cytotext. This is SCT, specialist cytotext. Anatomic path certified, anatomic path plus cyto, IAC, psych fellows, and path residents. And now just looking at this, who's got the most green? And it's an easy way to look. And so path AP and path AP plus cyto have the most green. Who has the most variable performance? The path residents, because they're the least trained. And so you see more variation. Surprisingly, the SCT showed a lot of variation. But this is the main key. You use all for the key, and then you compare it to those. So it's an easy way, using just desktop software, to do this kind of analysis. And it's very useful in all sorts of studies. So I just thought I'd share. And again, thanks to Deb Schutt from the Cleveland Clinic for showing me this originally. We've used it a lot. This is a bubble plot and shows distribution of interpretations. If things were perfect, there would be 100% correlation across this line. And it wasn't so. There was a lot of variation. But these were not necessarily the easiest images to interpret, because the images were chosen to illustrate difficult diagnostic parts as well as being easy images, and so there's a lot of variability. But it's the baseline, and it will be very important to see how this improves in the future. You know, if they were 1 degree off, not so bad. And most of the largest bubbles indicating the largest agreement are on the diagonal line, but it's not as good as we'd like. So, again, best correlation was by board-certified pathologists, with AP certified pathologists and cyto fellows following, and again, the residents were most variable. Best associated diagnostic category was non-neoplastic, and non-diagnostic was next, and malignant was after that. The atypical or the fuzzier categories of atypical, SUMP, and suspicious were not as well represented. But again, we had just introduced these terms. So, and this study did represent the interpretation of static digitized images. It wasn't like people were looking at a whole slide. And this was done prior to publication, and many of the images were difficult. Of interest, and I want to iterate again, this study and the whole Milan system was generated by volunteer effort with the help of the IASC Central Office using web-based tools available at most academic centers. And these studies can be done at low cost, so you aren't, not inhibited. Results of the study demonstrated uneven diagnostic performance and emphasized the need for a diagnostic system to get some sort of unity going. And again, it will serve as a baseline. Getting involved in these sorts of efforts has been personally very rewarding. I've gotten to go across the country, across the planet with groups of very, very impressive people, made great friends, evolved a family. And so I encourage you all to think about getting involved in your professional societies. Cytopathology is, of course, the best, but there are others out there. CAP committees. The CAP Cyto Committee is amazing. We get together, I just rotated off of it, but we get together 4 times a year. We work very hard, see the best material on the planet that they give us to, they use for their various programs. We write papers, generate data together, and so it is noticeably fattened my CV and our junior members also, and we welcome participation. In any case, the future. Milan website will be out later this year. We're trying to finish it now. And it will have all the images from the book, and it'll have diagnostic explanations, and there is no charge. Of course, anything we put up on the website, we expect to get stolen immediately. But if people give the website credit, it's appreciated. But we want to teach. There will be studies to refine the system in terms of grading, risk of malignancy, management correlation, and use of molecular markers. Anything that can help advance our diagnostic utility to the clinicians and improve patients' lives and outcomes, we're all for. We'll probably do another survey in 4 years, revise Atlas in 7 years. It's a wash, rinse, repeat. And for all the systems, because unless you do that, they won't remain vital. Some of the older systems, even looking back at things like Dr. Pap's original classification system, it fell apart because so many people started changing things, and it no longer had the same interpretation in different institutions. We can't afford to let that happen to modern diagnostic systems. And so there is a plan for each one of them to keep them vital. So, summary. Pretty good. We've described an evolution of a diagnostic terminology system in Cyto, and they have evolved to improve standardization of terminology, morphologic interpretation, and clinical utility. Starts off, perceived need, leading to expert group formation, pre-publication survey, atlas preparation, intra-observer study, reassessment, and repeat. So, thank you. Question?
Thank you for the beautiful presentation. I'm asking about the actual format of the report recommended. The pathologist would say malignant, comma, and then specify the entity, or malignant period, or what is the recommended?
The former. If you can, just like Bethesda GYN, that you have the category, and anything else you want to put in, certainly your freedom, but we have the general category and then the specifics. And so
it starts with the malignant, or the...
Yeah, or the benign neoplasm or benign SUMP, and then the explanatory note. And in the Milan book, there are examples of various formats. That each one of the chapters, in fact, that was started by Ritu Nayar from Northwestern when she did Bethesda GYN, is that she gave example notes that how they'd like to see it. And of course, that was also blessed by the NIH. And so we've always followed that model. So each one of the books, Paris and Milan, will have that. Yes, sir.
With current informatics technology now, you can use whole-side imaging for your correlation surveys
Right.
rather than static. And the question I have is, if you had used whole-side imaging, what do you think your correlations would have looked like?
Don't know, because a couple of reasons. One, the user interface for whole slide imaging is still lagging a bit,
Yeah.
and it's harder to use. I can pass glass across my microscope stage a lot faster than I can, study this whole slide image. I would think that the more information, the closer to correlation you would get. I mean, it's just like mentioned earlier. If you have many ways to examine something, each way you examine it leads you closer to the truth. If I have a lump of coal, it's dark, it weighs so much, it has so many facets, it has such a specific gravity. Each time I look at it, I get closer to the truth. You can talk about that in anatomic pathology. Each cell I look at leads me closer to finding out what the disease is, up into including the autopsy. Right. Yes.
So basically for cytology, in low-grade neoplasm, if it's benign, usually you can make a name for it.
Yeah.
So do you recommend to put a kind of favor something like the low-grade in your favor, most of the low-grade neoplasm you can diagnose it wasn't tumor or adenoma.
Yeah.
The same thing for high-grade, usually you can put a name, then you say it's suspicious for malignancy. Usually you can associate with a malignancy, then you as cytopathology are going to call.
I agree with being as specific as possible. That's what the surgeon wants. But first you put the general categories, so, neoplasm benign, pleomorphic adenoma, neoplasm malignant, high-grade mucoepidermoid carcinoma. And so, give them as much information as you can that you're comfortable with, and grow your expertise so you're more comfortable.
But that's not in Milan System, right?
Yeah, it is.
It is.
Yeah. But general category and then specific. Yes, sir.
Thank you very much first for the excellent presentation.
Thank
There's
you.
no question that the Milan System, the reporting system, is a major step forward in FNA reporting as well. I have two questions. The first question, what is the rate of implementation of the Milan System in the county among laboratories here in the U.S.?
Oh, I mean, how is it employed?
How many laboratories are applying currently the Milan System?
It's relatively new. We're looking at those numbers now. And so since really last use cap, when we really started pushing it, and the ASC before that, say 2 Novembers ago. So I don't have that number. I think that it's trying to gain consistency, that we have major authorities that are working on getting it extended everywhere, like Bill, that the books are selling well. Kind of indicates that, but I don't have a number for you.
And the second question is, do you see a role for molecular testing concurrent to the Milan reported testing? For example, especially for the category of neoplasms, where there is a big discrepancy between benign neoplasm and neoplasm accepted malignant potential in terms of rate of malignancy.
We're relying on that. We're relying on more and more molecular ancillary testing to help define these entities. And we can get suitable material from a needle rinse that, you can do PCR, get enough to look at, you can do sequencing on it. And so, we want involvement, we want papers, we want to have references such that we can include it in future iterations of Milan. We're absolutely thrilled about the advancements in genetics. Other question with someone else.
As far as the cell blocks, do you have any idea of how many or percentages that have acceptable cell blocks in there? I mean,
We didn't have that from our survey versus acceptable, non-acceptable cell blocks. Here's a good study for you or a resident. That would be an excellent one. we could use that. It would be, what's your success rate at getting cell blocks? And we found that to be an issue when we used to do that. I mean, if you're using agar blocks or using clot sections, you can prepare a cell block in a number of different ways. There's the Milan System where you can spin down a needle-rinse specimen. There you can throw it in some thrombin or let it clot in a slide or use agar. And I found that personally, I did not like the agar, and I wasn't thrilled with thrombin, but letting it clot on a slide worked well. But other people may have different techniques and different experiences. But I think it's a excellent question and needs to be explored. So write that up. Yes.
Regarding the survey, very interesting survey you performed.
Yes, sir.
How people applied it. So, two questions. What do you consider more important, inter-observer reproducibility or accuracy? The constructed-
It's all important, Bartosz.
And what can be done to improve the inter-observer reproducibility?
We got consistent terminology, and that we,
Are you trying to modify this according, like there were cases that were clearly red.
yeah.
Can you go back to what was wrong in those cases and what can be altered in the procedure?
We're dedicated to modifying anything based on evidence. And so if we can find a term or something that allows for better inter-observer reproducibility, we're all for it. And the accuracy depends upon how the entity is defined. And so, but yeah, it's always. And ultimately, the goal is the patient. The ultimately is to do better. Yes. Sir.
Is anybody doing image analysis and machine learning to try to figure some of these things out? Google just did a thing with 750,000 retina embryos and knew nothing else and predicted hypertension in 70% accurately.
And I have a person who I'm going to give my job to someday. We hired her, and she's doing this on urines. And so she's doing deep learning image analysis on GU samples. No one I know of offhand, is doing it on salivary gland. But it's the hot area, and that and circulating tumor cells are two big areas for future development, and cell-free DNA.
Yeah.
Thank you.